I'd like to introduce John Carroll, who we all know, to discuss about PFO, the questions that remain unanswered, and the questions from the trials to be answered.
So I have a couple of pre-questions. Yes. Could we put those up? So open up your app.
Just 1 second. Guys, can we just open up the, just turn the thing live?
Okay, your patient was hospitalized with a DVT and a PE on the day after admission. Your patient then had a stroke due to a presumed paradoxical embolism. The best strategy for prevention of recurrent stroke is?
More information. More information.
Best strategy. Strategy.
Good. Diversity of opinion. Good. All right. Again, these are unanswered questions. Next, your patient is a 30-year-old woman with a recent stroke with brain imaging consistent with an embolic mechanism. She has a PFO with a small shunt and no ASA. On further questioning, she has had 2 miscarriages and wants to try again. What would you recommend? Good. All right. Just 2 questions, that's all. So let's go to the slides. All right. So my disclosures, and as part of this, my career has been heavily influenced by many of the people in this room. I'm an adult cardiologist. I do a lot of structural interventions. And I started doing PFO closure right after I moved to Denver from the University of Chicago in 1996. Mark Busek and Chen called me up and said, well, we have a problem. We're doing a clinical trial in PFO closure, and the hospital administration does not like 65-year-olds with COPD taking up a pediatric bed. Would you like to learn how to do it? And that really started the kind of collaboration that I think has led, certainly in my career, but in many aspects, to the advantages of collaboration that Lee pointed out the other day. As you really learn, and sometimes more, from people who aren't exactly in your area, but are in a related area. And I think the innovation and the courage that has gone on in development of pediatric interventional cardiology really allowed structural heart disease to blossom in the adult world. So that's my editorial comment for the morning. There are 2 recent reviews. I point the attention to the bottom one in stroke that's just came out, written by 2 of my co-steering committee members, Jeff Safer and David Thaler, in the RESPECT trial, and read the stroke article, because it really shows how the neurology community has evolved. And one of the unanswered questions from the clinical trials is, will the stroke neurology come around in terms of accepting PFO closure? And I think this shows how far they've come. And the Canadian Neurology Stroke Guidelines that came out in December really showed how to put the data together and how stroke care will change. So I made a list of some of the 8 big unsettled questions. issues coming out of these randomized clinical trials. I'm not going to be able to cover all of them, but these are sort of the ones that rose to the top of my list. I'm certainly not going to approach the topics of migraine and hypoxemia. Probably the most common issue I've run into, we have a PFO clinic. We've had it since we were involved in the clinical trials, and it's both stroke neurologist and myself, and now my colleague, Dom Wichter. We see patients together, which really helps for the patients, both efficient use of their time, but also to ferret out unanswered questions. So in these older patients, how old are we talking about? The first thing, they clearly need much more prolonged monitoring than a 30-year-old who has no risk factors for AFib. They're not obese, they're not hypertensive. Secondly, they're more likely to have other competing risk factors, and they were excluded from the trials because of that. That is, a stroke in a 70-year-old with a PFO could be due to a lot of other causes. But on the other hand, as we age, and one of the mysteries of this field is why in the pediatric and the very young adult population, where PFOs are as common as, if not more common than a 40-year-old, why is this stroke mechanism so rare? And some of it is this aging-related increase in hypercoagulability and a tendency for venous thromboembolism. And in respect, in the subgroup analysis, if we broke it down by age in a binary fashion or continuous fashion, we didn't really see any differential effect of the device being a greater benefit in younger or older patients. But we did, in respect, since 1 in 5 patients enrolled in respect by the time we did our late follow-up were now over the age of 60. It's what happens when you have a long trial, unintended consequence. But it did allow us to find that those who were over 60 who had a recurrent ischemic stroke, most of the time it was from a known mechanism. They had developed AFib, carotid disease, etc. So this is rather sobering when you're sitting down with a 70-year-old talking about PFO closure, because these other stroke mechanisms are clearly active. So in summary, the older patient is probably one area where a randomized clinical trial would be useful. Whether it will ever be done is another thing. But it goes back to the heart of this whole area of an individualized assessment and discussion with the patient. And certainly if they have other needs for anticoagulation, that changes the dynamic. But when we had the panel with the FDA, we made the case that it would be unwise to just say no one above the age of 60 should have PFO closure, because that's arbitrary and people age differently, and there are many people older who are free of everything but aging in terms of vascular risk factors. So what about the patient with overt VTE and paradoxical embolic stroke? First of all, if you had an active venothromboembolic issue going on at the time of your presumed PFO-mediated stroke, you couldn't get into these trials. You were excluded. And the central point is that PFO closure is a very targeted therapy for one stroke mechanism, and it's not going to do anything to underlying proclivity to venothromboembolic disease. So keep that in mind. So this is a clot that came out of a 30-year-old's middle cerebral artery who had an acute stroke and was PFO mediated, and we eventually closed her PFO. And I just bring out one topic that's always fascinated me is, can you look at a thrombus and see anything suggesting where it came from? And this was one trial that showed a little tendency toward differentiation of cardioembolic stroke from others. And maybe we'll learn more and more, because given the acute stroke therapy changing such that retrieving clot is increasingly common, gives some potential research for pathophysiology. So in this field, it is presumed that these people have both paradoxical embolism, and therefore it started as a thrombus somewhere, and is it, and you look for a DVT and you don't find it. First of all, you have to consider the fact that the middle cerebral artery is 2 to 3 millimeters in diameter, so we're talking about very small clots, really below the ability of much of our venous-based imaging to look for. You still look for it, and some studies show that you can, if you look for it, come up with it, and how to look, some of the different testing that should be done, and in whom to look, certainly if there's any historical suggestion that they might have a VTE, or on physical examination, that's where you definitely need to look. This is a patient who had PFO closure. If you see within this array of devices from Ace Hardware, there is a closure device. And that's because this elderly person had a stroke that had a typical topography of embolism, a cortical stroke, and lo and behold, on TEE, they had not only a PFO, but they had a flipper on a pacemaker lead in the RA. So that's a rather compelling issue, and but opened up a can of worms of so many people have right-sided leads and PFOs, and in this elderly patient population, strokes are not rare, and how often is this the mechanism? It's a tough issue. Finally, I put up the ASCOD is one of the several systems that the neurologists use to try to come up with what caused the stroke. And we need to respect the stroke neurologist's job of determining what a stroke mechanism is in an individual patient is not an easy task at all. Even if they have AFib, to say it was due to AFib is connecting dots where the dots may not really be connected. And so the highest level of causality is potentially causal in this, and it just shows you the challenge they have of really saying what a stroke mechanism is. We did see a bizarre finding, unexpected finding in respect, in a higher rate of venous thromboembolic events in the device arm over a 9-year follow-up period. This kind of freaked out us in the middle of the trial, and people were instructed to be extra vigilant, but it wasn't found to be associated with the device. We never saw any thrombus on device. Of course, it doesn't make sense for a DVT, but for a PE, it could. And most occurred years after the procedure, so it's hard to say, gee, it was related to the femoral vein stick, etc. So first of all, in respect, we saw a higher rate of history, not active DVT, but of a history than expected in the general population. So did we enroll some patients with kind of a form-fruste VTE, and this stroke was their second event? And that really should raise the issue of whether anticoagulation should be used. Secondly, RESPECT was one of the trials where the stroke neurologist enrolling the patient in the trial selected the medical therapy, and warfarin was one of the 4 arms. And so there was a protocol-driven imbalance of warfarin therapy in about 20% of the medical patients were on warfarin, and almost 0 in the device arm, at least at the time of randomization. And that did statistically account for some of this differential. And also, it's important that we had 114 patients in RESPECT who were enrolled and randomized to the device arm and had been put on by their clinicians initially on warfarin. And we took them off of warfarin. So, were there subtle things in their history that made a clinician choose warfarin versus aspirin? Don't know. So another issue is with anticoagulation. If you look at all the 6 randomized trials, now the greatest treatment effect were in those trials where the comparator was antiplatelet therapy. And we really don't know whether PFO closure is superior to anticoagulation. One can easily make the case that for a 40-year-old, it's much better to have PFO closure and aspirin than 40 years of a NOAC or a warfarin. And in a subgroup analysis of the treatment effect in RESPECT was limited to those who had randomized to antiplatelet therapy. So one of the unknown issues is anticoagulation. Should it be now considered as an alternative medical strategy with all the caveats? So to really determine this issue of VTE, PFO, and paradoxical stroke, we don't have really strong evidence. You're going to have to use clinical judgment, and it goes down to the whole shared decision-making that's often used in people with active VT in terms of the prolonged anticoagulation. What about the patient with hypercoagulability? First of all, as a clotter once told me, well, by definition, all these people are hypercoagulable, because if they have an unprovoked thrombus that embolizes, they're atypical. Something they're forming clots. So two different kinds of hypercoagulability states, and the pure venous ones probably do increase the tendency to form clots, although it's doing routine testing of hypercoagulability or states is just not recommended in general in people coming in with one potentially thromboembolic event. On the other hand, there are some states that are mixed arterial venous hypercoagulability states, and one of those is antiphospholipid antibodies, and certainly when you're taking a history and a woman has a history of miscarriages, this is one thing to look for, because it's a very different treatment paradigm in someone with clear APL, where they do have to go on lifelong anticoagulation, and only warfarin's been studied. So again, in terms of the pathophysiologic thinking of this, that there has to be something else that comes along that gives these people a paradoxical embolism, that they have the anatomical substrate for right to left shunting, but what happens? And some people feel that just as we age, we're all forming little clots, and guess what? The lung is a great filter to clean up these small clots, and if you have something that bypasses that filter, which can be anything, pulmonary AVM versus a PFO versus an ASD, then they can have a 2 millimeter clot that can cause you to be hemiparetic. So not well addressed in this. We started in RESPECT doing complete hypercoagulability testing, but since enrollment was slow, the company was worried about money, we only did rule out the APL testing that continued. It's in the stroke guidelines and the complete panel of thrombophilia testing is not recommended, low diagnostic yield, high costs, but you should individualize this. There are some patients where you might really come across more, and it may make a difference long-term in them, although there's a lot of debate about that. So in summary, individualized decision-making, get rid of prothrombic medications. The thrombus on the PFO device shown in the ultrasound below was not a patient in the trial, but a patient I treated outside of a trial, and I didn't stop her birth control pills, and this is what she developed, and we gave her warfarin, it went away, stopped her estrogen-based birth control pills, and it never reoccurred. So the big message is the RCTs are very strong in terms of showing the superiority of PFO closure plus aspirin versus antiplatelet therapy alone, but many patients you'll be seeing will fall outside of the inclusion-exclusion criteria for the trials, and it gets you into discussing. And this is a great old article of a guy I know from Connecticut who actually went up to Mass General and has PFO closure. Mass General didn't enroll in the PFO trials. They had a very active, but it's all about patient choice, and Selection of a treatment strategy should be patient-centric, informed by clinical trial evidence, and tailored to the presentation findings and preferences of each individual. RCTs do inform your decision, and people who don't fit into those but don't give all the answers, and we'll see whether there is going to be the support for doing more RCTs. Unfortunately, without large registries mandated in the US at least, we can't really have that as another mechanism of learning in these different subgroups, things like safety and efficacy. So let's do the post questions. 2 questions. All right, let's see. DVT and PE were rare but occurred more commonly in the device versus the medical arm of respect. Which of the following statements concerning these data are true? So there was a higher rate of a history of DVT in patients enrolled in respect than in the general population. So number 1 was true. Warfarin was allowed in respect, and none of these patients we saw had device thrombus. So all of the above. Next. All PFO closure trials had a lower and upper age limit. Which of the following is true? The FDA used this fact to limit PFO closure to patients between 18 and 60. PFO closure after the age of 60 was associated with a higher rate of atrial fibrillation in the REDUCE trial. PFO closure should only be done by adult cardiologists. PFO trials in the very young and older patients are needed to answer the questions. So, thank you.
Question back.
Yep.
Actually, I have 2 questions for you, if you don't mind. The first one relates to a very, clinical scenario. Patients I actually had the chance to see in clinic with one of the faculty. 39-year-old woman tested positive for ATL, already had a stroke, and is coming to the clinic for a potential PFO closure. The rationale being that despite the fact that she will be requiring anticoagulation, she was thinking about it as another activity measure for risk reduction for potential repeat stroke. So what would be your
I agree with that strategy, and with our clotters, the hematologists who see these patients with APL, we think that is a reasonable strategy to outline to such a patient, with a caveat that it's only going to prevent paradoxical embolic. The APL patients can have in situ thrombus. They have to be on lifelong anticoagulation in addition, and it goes to this general issue of people who have VTE too. Guess what? There are failures of anticoagulation. When they have their knee replaced, they come off of it, and if you can protect them from a stroke, from a paradoxical embolism, that has huge value. Yeah.
And the second question is when you go ahead and close the PFO, especially with like big devices, like 35mm devices, for patients who are prone to develop atrial fibrillation down the line in their life, are we in some way hindering the possibility for them to undergo pulmonary vein isolation down the line? Like, are we cutting the way for the electrophysiologist to go transeptal down the line and be able to do PCI?
The answer is, you may make it a little more difficult, but usually they can find the plenty of room in the septum that they still can cross over. And the Omplotzer is hard to go through, but some people have done transeptals through cardioform and not had that deter where they make their puncture to do a AFib ablation. Yes?
Maybe it's less of a concern because by 5 years they're all back at AFib, but it may make it hard
one question, what about the pediatric patient? I got a referral last week. She's 12 years old, has sickle cell disease, SS, has MRI imaging of the brain with a stroke, had a symptomatic TIA, and a positive bubble study.
I don't know, Lee.
Guys, we didn't hear the question back here. We didn't hear the question back.
So it's a 12-year-old with sickle cell disease with right to left shunting, PFO, and a brain imaging consistent with an embolic stroke. Is that?
John's answer is sort of the opposite of Steve, that should be just dealt with by the pediatric cardiologist.
Yes. I think these young people with that's very challenging, and I don't know whether there's been any even observational collection of cases in a pediatric population with presumed paradoxical embolism. It's a different.
What would you do with the interesting Pisces study?
Probably chose it. There's a lot of motivation from the hematologists as well, and the neurologists.
Go.
Nice question about the device size. One of the guys I work with is convinced that a 35 amplats is more likely to be associated with procedure-related AF than a 25. So has a tendency to use the smaller device. Is that looked at in respect of
The 35 versus the 25?
In terms of AFib?
procedure-related AF?
Well, first of all, it's important to realize that in all the trials, AFib was more common in device arms, but most of the AFib was transient periprocedural and did not predict long-term recurrence of AFib, number one. Number two, all the trials didn't use what we would do today in terms of during enrollment of excluding people with occult paroxysmal AFib. Like RESPECT, Holter monitor was done in a few, but it's mainly
8-hour Holter, right? Like there's no prolonged monitoring, that's a
Yeah.
case that case.
So excluding people with occult paroxysmal AFib is something that really has changed in the workup of these patients. There's kind of an ongoing debate of, okay, a 60-year-old who's hypertensive and obese, you really got to look at least a month. What about a 25-year-old, a week, 2 weeks? But you,
Not even studied, right?
yeah,
Like those
so-
two trials in New England were both, like one is over 40, one is, the Holter study's over 55, the implantable device is over 40.
all the prolonged monitoring studies, if you look at the average ages, it was 60, 70 years of age. We do not know whether device size increases or decreases AFib proclivity, but again, it's typically transient.
Has anyone closed a PFO in a patient? So I had one referred to my office. The mom came in with a teenage daughter that had been struggling with migraines for like 10 years or something crazy, and tried every drug in the world, and now she was going around begging for PFO closures. There was never an episode of stroke or imaging study to suggest it, but she was convinced that a PFO closure would take away her migraines.
Well, as you know, we just are lacking clear evidence, not that it doesn't relieve migraine in some patients, but in whom. The patient selection is still open, and there's a recrudescence of interest in doing a randomized trial in migraine with trying to better define the patient population, because yes, there are responders, but there are a lot of people who don't respond. Migraine's a very complex disorder, and for cardiologists to think that we should just plop a device in and see if we help someone, that's we need more evidence.
It's kind of a related question that Toby just asked is, younger patients with repetitive TIAs, just TIAs, short-lasting, brain imaging normal, but repeated episodes of TIAs with a positive bubble study and PFO, obviously. What's your approach in those situations? Because the trials, they do not specifically address that particular population, I think. So what do you do in those cases?
So the first PFO closure trial included people with TIAs, and in retrospect was strongly criticized by the neurology community, just because TIA is a diverse syndrome that can have multiple mechanisms. And so my answer is, I see everyone with a stroke neurologist and let them think about the TIA. Was it a major TIA? Was it with symptoms that suggested a location that might have been cortical rather than lacunar, et cetera, et cetera? And so occasionally I have closed PFOs in people with TIAs after a stroke neurologist and the patient, we've all had a discussion of this. So it's kind of an unknown, and that's why I put it as one of the unanswered issues in terms of not having a strong randomized clinical trial base is a TIA. Yeah.
Stroke during pregnancy.
Yeah.
Timing of PFO closure and what antiplatelet or anticoagulation regimen would be recommended in such case?
So someone in the middle of
Yeah, so
pregnancy?
it's like a 31-year-old pregnant. She's 36, had a stroke, and in fact, she didn't have she had a large PFO. No other, and the mechanism of stroke was certainly embolic, and yeah, so timing of closure, and the debate we had. I mean, we felt PFO closure we should wait till she delivered, But the question is, what regimen would be recommended in this case? Would people feel comfortable with single antiplatelet, dual, or low molecular heparin, full anticoagulation versus prophylactic dose of enoxaparin?
I don't have, and it's certainly not an evidence-based, but this is where I revert to what you've heard repeatedly is these are not decisions you should be making on your own. You have high-risk pregnancy people, you have your neurologists, and you get together with the patient family and discuss these issues. Someone like that, I don't think aspirin alone would be effective, and some antithrombotic therapy would be wise. Using even warfarin is what's, once you get beyond the teratogenic issues, early pregnancy is used by some. So they clearly need protection. Doing PFO closure in the midst of pregnancy, if they're 30, just like mitral valvuloplasty, if we get people out fairly far where we're not concerned about X-ray exposure, it could be done. And you might think about that in someone pregnant with, say, active thrombus, big PFO, and again, it's an interventional therapy that's for a prevention, and therefore the standards are very different, and the key standard that has to be dramatically different is safety of the procedure to make it in the world of prevention, and that goes for migraine too. Yeah.
John, just one of the issues with those types of, so those patients sometimes get referred after the fact. So
Right.
say 8 months later after they've had a stroke and pregnancy, hypercoagulable state, and then the question is, should you close it at that point? If they're not going to get pregnant again, for instance, should you be closing it because they had a reason to have a stroke and they're not going to get pregnant again? And of course, those patients were not enrolled in any type of trial. So I find that's a very difficult discussion to have. Not difficult, but it's a challenging discussion to have with the patient, right? Because obviously they don't want to have another event, despite the fact that you have a good reason. And, pregnancy, it's, if it's not going to happen again, it's a different story.
Yep.
Do you have a bedside assay clinic to detect who's really got pregnant again, or?
Well, there are things that people can do. There are things that people can do outside of cardiology to prevent pregnancy. There are procedures and
So I
medicine.
think that line of thinking actually has a parallel in the VTE world of provoked versus unprovoked, because that does impact on the duration of anticoagulation. So you could apply the same similar thinking to that situation if they're not going to have another provoked. But it's pretty dicey saying that that person has demonstrated a tendency to develop clot already, and maybe it won't be with pregnancy, but it'll be with a plane trip or long plane trip or whatever other environmental factor might come along. Yes, sir.
One question for about two of the papers that have come out. So one is closed. I wanted to hear your thoughts on the anticoagulation group, and that
Yeah.
was part of the randomization. And the second, we've gotten a few referrals since that JAMA article came out with the patients who have PFO have more strokes in surgery. I've had a few orthopedic surgeons sending patients, refusing, telling patients, I don't feel comfortable because your echo shows a PFO with an atrial septal aneurysm. You need to have this closed before I fix your shoulder because you're a pitcher. Like stuff like that.
Yeah.
I'm not sure what to do with this. And they're getting, the evidence is based on this 180,000 retrospective art. I don't know, are you dealing with this at all?
Yeah.
Your orthopedic surgeons can read.
So
Books on audio.
the close is easy. So close was the French trial, and it had 3 arms. It was probably the best designed trial. It wasn't device company sponsored. It was the French Ministry of Health. But something happened in terms of funding was pulled, and so they didn't complete enrollment in the arm that would have compared anticoagulation to antiplatelet to PFO closure plus aspirin. And so it showed a tendency toward lower recurrent stroke in those who got anticoagulation versus antiplatelet, but it was underpowered because it was under-enrolled, and so it was not definitive, but it is upsetting the fruit basket of the neurology community that for the last decade had says antiplatelet therapy is fine for these patients. It may not be so, and we'll see how AAN and other organizations. The other trial is one that showed this higher stroke rate in people with PFOs undergoing non-cardiac, a variety of different surgeries. I don't know what to do with that. That opens up a huge can of worms. And, but it doesn't justify going around closing PFOs as primary prevention. A lot of talk of how you would organize and have a trial on primary prevention of PFO closure in a very select group of people, maybe with ASAs and large shunts. And this same sort of thing is, what a can of worms that opens up. I don't know what, but you could still say best practices of preventing perioperative DVT, et cetera, may have an impact, and sorry, tough. That's the number of questions really represent how we've made some progress in some evidence base, but it's a can of worms and in many other areas.
Thanks.